Hello guys, welcome back to my channel. Today I'll discuss about Aogd Bulletin December 2024. Okay, so first topic in this bulletin is role of sentinel lymph node in gynecological cancer. Sorry, so sentinel lymph nodes are we all know sentinel lymph nodes are first draining lymph nodes. Okay, these are the first draining lymph nodes. So sentinel is a word derived from sentinella, okay, which means watchman. Something like watchman is the first person to be attacked by any external people, right? In that way, sentinella means watchman. Okay, so actually, sentinel lymph node biopsy in management it created intraoperative complications and postoperative morbidities like lymphedema and when we do complete lymphadenectomy, it results in lymphedema. Lymphedema. Okay, so that's why this concept of sentinel lymph node biopsy has been come. So if there is only one lymph node if we remove, then we can prevent this intraoperative and postoperative complications. Okay. So initially, before jumping into what is sentinel lymph node, we learn about what is the lymphatic drainage of pelvic, female pelvic organs. First, coming to vulva, if you see vulva, this is totally vulva, and these red things are superficial inguinal nodes. Superficial inguinal nodes. So first, initially it goes to superficial inguinal nodes, then deep, then finally into the external iliac nodes. Okay, so superficial, deep, external iliac. So first important is superficial and external iliac. Superficial, if it is superficial, then deep, then external iliac. Superficial, then deep, then external iliac. Okay. These are the lymphatic supply of vulva. Mm, and what is clockwork node? It is the most cephalid deep inguinal node absent in 50% of the cases. It's the most cephalid deep inguinal. This is the clockwork. This part is clockwork. Okay. So most cephalid. So the most common site of detection of sentinel lymph nodes in endometrial cancer is external iliac and obturator group of lymph nodes. Okay, so in endometrial cancer, the most sentinel lymph node is this thing, external iliac and obturator. Once we learn about cervix and uterus lymph node supply. So you draw the uterus and cervix, then draw aorta because aorta pre and parietic lymph nodes are present. Then aorta is divided into two types, na? External iliac and internal iliac. So internal iliac side is in internal iliac lymph nodes, external side lymph nodes are external iliac lymph nodes. Okay, near the sacrum bone is sacral lymph nodes. Okay, side is obturator lymph nodes, and down you have superficial inguinal lymph nodes. This is the lymphatic supply of uterus and cervix. Okay, so here they are saying that these external iliac lymph nodes, and obturator lymph nodes are these sentinel lymph nodes in case of endometrial cancer. Okay, then ovaries, cervix also mainly initially drains on the paracervical lymph nodes. Then it follows the uterus only. Okay, internal iliac, external iliac, presacral. These are primary sites. Secondaries are the common iliac, para-aortic, inguinal. Okay, so inguinal lymph nodes involvement in cervix are secondary. Primary is all the iliac and presacral. Okay, iliac and presacral. Ovaries drain into para-aortic along the infundibulopelvic ligament. Now we learn how to map the sentinel lymph node. So we know what is sentinel lymph node. It is the first lymph node. So how to map it? There are different detection methods. One is CRN. Okay, this is the mnemonic C, R, and N. Okay, what is C? Is calorimetric. Okay, calorimetric. R is radionuclear. N is near infrared. Okay, so what are the different dyes used? Isosulfate blue or methylene blue. We all know this methylene blue. So calorimetric uses methylene blue. We take 5 ml of methylene blue, 1% methylene blue, and we inject into the cervix for cervical cancer and even for endometrial cancer. Okay, mainly in vulval cancer, you inject into the tumor site. Okay, methylene blue is easily available. Every OT has methylene blue, right? So there is no extensive equipment required. But the diagnostic accuracy is poor. Hypersensitivity reaction is 1%. Methemoglobinemia, serotonin syndrome occurs with calorimetric detection. Okay. Next is radionuclear method. Radionuclear method, name only saying it uses some radio-labeled dye, some radio-labeled substance. That is technetium 99. Technetium 99. Okay, here we'll take 1 ml of that technetium-99 and we'll inject into that organ preoperatively. Okay, then we'll do SPECT scan, that is single photo emission CT scan. Okay, so this radio labeled one uh, uh, will show the light after a penetration. It's a better diagnostic accuracy. And but here a CT scan is required, PET CT is required, extensive equipment is required. Okay, and radio it takes longer hospital stay for the patient. Okay, last method is near infrared. Okay, it is also same like radionuclide only. So we'll use ICG thing. Okay, that light will be emitted at 830 nanometers. Okay, 830 nanometers. So ICG is indocyanine grain. Okay, if you have robotic instruments, you can see this kind of dye because robotic has one filter which can detect ICG. Okay, so this ICG dilution is done before injection, and we'll give it. Okay, we can visualize by these filters and the requirement of that filter kind of instrument is required. Near infrared imaging equipment is required. Okay, and ICG should be avoided in case of liver failure and any iodine allergy. Okay, so what is central lymph node biopsy techniques is calorimetric, then radionuclear, third is near infrared. Yes, right, calorimetric requires methylene blue, radionuclear requires technetium 99, and near infrared required that ICG, indocyanine gland. Okay. So this is the flowchart you should write. After injecting in the primary tumor, it detects the central lymph node. Then all map central lymph nodes should be excised. If you while doing surgery, if you suspect any enlarged or suspicious lymph node, then also you remove that. If central lymph node, you'll send that to lab. It takes about 15 minutes to get the report. So if the central lymph node is negative, then ultra staging is done. If it is positive, then we'll do complete lymph node dissection. Okay. Then if the central lymph node is fails, mapping only fails, we couldn't inject anything, then specific lymph node dissection, whatever suspicions, you can do that. Okay. Then there is an algorithm known as Memorial Sloan Kettering MSK algorithm. Okay, like CSK it is MSK. Okay, MSK algorithm is there for central lymph node pathology. It is like first central lymph node we'll see the HPE. If positive, we'll follow the protocol. If negative, then further evaluation. Two 5 micron meter sections of node are cut and they're adjacent to each other. One section is HPE, HND stain, and one for keratin, AE1 and AE3. Now the two blocks are about 15 micrometers apart. Okay, if negative, again once we'll check by cutting the sections into two parts. In one we'll give HNE staining and another we'll give this AE cytokeratin stainings, and we'll again check it. Okay, that is MSK algorithm. Okay, so what's the role of central lymph node in vulval cancer? We all know vulval cancer biopsy, central lymph node biopsy is indicated if the vulval cancer, for example, this is vulva. Okay, so if the vulval cancer is unifocal and size of the tumor is less than 4 centimeter, and you can suspect some groin lymph nodes. Clinically only you can suspect some groin lymph nodes. Then you'll do this central lymph node biopsy. Okay, within 1 centimeter of midline, you will do bilateral detection is performed. Both sides you will check for central lymph node. Okay, so there are studies going on. With if there is evidence in vulval cancer. One is groins VI study, other is COG 173 study. Just learn the name. Okay, then coming to role of central lymph node biopsy in endometrial cancer. You know, na, endometrial cancer will inject it and um, generally we can give into the myometrium. Histoscopically, we can give it, sorry, endometrium histoscopically, but best preferred is by giving it intracervically. Okay. Uh, mm, so there are some trials going on like Endo 3 trial and SENEC trial for endometrial cancer, central lymph node. So what is the role of central lymph node in cervical cancer? In cervical cancer, same thing. In stage 1, we can select whether we can do complete lymph node dissection or central lymph node dissection is okay that way. Okay. So cervical cancer mainly studies as empty con. See, they'll give a study and they'll ask you what is the cancer. Okay, so Centicol study is for cervical cancer. Senec study is for endometrial cancer. Endo, you know, endometrial. So Senec is for endometrial, whereas Centicol is for cervical. Okay, there's one more study known as Centix, Centicol 3. These are all for cervical. Ovarian cancer is early stages sentinel lymph node procedure can be done. Early stage ovarian cancer, you can go for sentinel lymph node biopsy. Okay. So what is the conclusion of this sentinel lymph node? More relevant in management of gynae cancer in this era. So this will shows the levels of evidence. Like in vulval endometrial, this is 2A evidence, whereas cervix has 2B. Even in ovary, it is still experimental. There is no level of evidence on ovary. Okay. So central lymph nodes are lymph node biopsy has the potential. It reduces the postoperative morbidity of the patient by providing them with better quality of life. Most of the international guidelines are now recommend biopsy, central lymph node biopsy as alternative and safe approach. Systematic lymphadenectomy is carefully selected in case of endometrium, vulval, and cancer cervix. Its role in ovarian cancer is yet to be established. Most studies on this topic will explore the benefits. Okay, this is about sentinel lymph node biopsy. Now coming to stump. What is stump? Smooth muscle tumor of uncertain malignant potential. In 1970s only they described this. In 2020, WHO classification says that mesenchymal origin of uterine body. These stump tumors are from mesenchymal origin of uterine body, and it is the second most common category of uterine tumors. Incidence is only 0.01%. It's a rare entity. Okay, clinical features are same like fibroid uterus. Okay, whatever fibroid uterus have, like pelvic pressure, pain, dysuria, constipation, menstrual irregularity, these are present in stump, and 40 to 50 years of age is same. Okay, if you see imaging studies, MRI is best. Both stump and fibroid are often exhibit the hollow ball sign on PET scan. Okay, so hollow ball sign is not specific for stump. It is seen even in fibroids. A fibrous knot, it is seen in leiomyosarcoma. Okay. Stumps resemble on HPE also it resembles fibroid with well circumscribed non-encapsulated masses. Okay. Uh, uh, their borders may appear pushing or even focally permeative. If you see the borders of the stump, there is permeative, they're inserting into something. Cut surface is usually tangled, white, firm, overall appearance. Additional findings such as signs of infarction, hemorrhage are seen. Stump has histopathology three varieties: spindle cell, myxoid, and epithelial varieties. Epithelioid varieties. Spindle cell, myxoid, and epithelioid variety. Okay, and there is vascular invasion, permeative margins, depth of myometrial invasion, and presence of epithelioid myxoid histology. These indicate the these are parameters seen in histopathology. Okay. Hmm. Then, if you see cellular atypias and all, they are negative, whereas coagulative necrosis is seen, and mitotic index is also less than 10. Okay, how to differentiate stump with leiomyoma and leiomyosarcoma? This is main thing, na? This is the main topic of this point. So basically, is smooth muscle tumor is generally is positive for desmin, okay, and other Carl Desmond and all. So we'll see some tumor markers, for example. Um, Estrogen and progesterone are positive in stump, whereas P60 and P53 are plus minus in stump. Okay, whereas in case of leiomyosarcoma, it is reverse. Estrogen and progesterone is plus minus, whereas it is the P60 and P50 is P53 is positive in leiomyosarcoma. So in this way, you can differentiate leiomyosarcoma and stump. Okay, that's it. Stump management. If now the patient you did a hysterectomy for fibroid. It's a very big fibroid. And the pathology report she came after 1 week with stump. What should do? What should you do now? Okay. Uh, Actually, surgery is the main treatment. If you get even in PET CT also, if you get that halo ball sign or something, surgery is the main treatment. Okay. Basically you do total hysterectomy. There is no need of doing bilateral salpingoplectomy compulsory. Abdominal, vaginal, and minimal invasive techniques also you can do. However, minimal invasive, the use of morcellation, if you do, there will be spread of that sarcoma cells. Okay, so peritoneal implants can occur and disease upstaging can occur. So better go for laparotomy. Okay, for reproductive age, fertility aspiration and aspirants and fertility preserving surgeries, like you just remove that stump, myomectomy is the best one. Same like fibroids you do. Okay, but you should follow thorough consultation. Childbearing once completed hysterectomy is the strongest recommended to minimize the future risk. So, stump is something like it has a late recurrences. Recurrence risk is 7 to 8, 28%. Okay, and if you have stump, if the patient has stump, the median survival is 5.5 years. Which type of cancer? So, if your patient came at 40 years with fibroid uterus and the HPE report shows it's stump, then her mean survival is only 45 to 46 years. Okay, regular follow-up with checkup is needed. Every 6 monthly for 5 yearly should be done because 5 years only. Then annually, if she is alive, then annually should be done. Survival should be include gynecological examination, chest X-ray, abdominal pelvic ultrasound, CT, and all. For those who undergo myomectomy to preserve fertility, annual and pelvic MRI and alternating with CT should be done. Okay. If a patient came with recurrence, what should you do? Like recurrences have reported in pelvis, uterus, retroperitoneum, even in lungs, liver, and bone, there is stump. Okay, so adjuvant therapies have limited data. Uh, so chemotherapeutic agents can be used as salvage, like doxorubicin, cisplatin, in that way. Okay, even hormone treatment like progesterone, aromatase inhibitors can be used. Like same treatment, fibroid, what you'll do that way. So conclusion is stumps are rare and complex to and smooth muscle tumors that are present. What is stump? Smooth muscle tumor of unknown malignant potential, right? And let's confirm it with smooth muscle tumor of uncertain malignant potential, correct? So these are smooth muscle tumors that present unique challenges in the diagnosis and management. Due to limited number of cases and absence of established guidelines, such NCCN treatment decisions often require individualized approach. Hysterectomy remains the recommended treatment for the women who are completed childbearing. However, for those desiring fertility, a conservative approach combined with vigilant monitoring is advised. The intricate clinical and pathological features of stump underscore the importance of management by specialists with advanced expertise in gynecology, oncology, and soft tissue sarcomas to ensure possible care. Key point stump is a type of smooth muscle tumor that cannot be classified as clearly benign or malignant. Stump can occur in any location where smooth muscles are present, but they're mostly common in uterus. Okay, stumps exhibit range of physiological features like cellular mycological activity, necrosis, but these features are not sufficient to classify the tumor as malignant. So, stump means it's not like malignant. Okay, but the prognosis is poor. Stump are often asymptomatic, but they cause symptoms such as pelvic pain, abnormal vaginal bleeding, and palpable mass. Imaging ultrasound CT MRI can be used to evaluate the tumor and assess for any signs of malignancy. The treatment is often surgical with options ranging from myomectomy to hysterectomy. The prognosis is generally good, but the tumor can exhibit unpredictable behavior. Oh, prognosis is good, but unpredictable behavior that there is small risk of malignant transformation. Regular follow-up is recommended to monitor for any signs of recurrence and malignant transformation. So I here they gave this median survival for recurrence. If the stump recurs, then the median survival rate is only 5.5 years. Okay, that's it about stump. Next point of discussion is post-surgical management of carcinoma endometrium. I'll tell you next part. This one. Okay.